Hi there, and welcome to the Surviving and Thriving in Residency podcast. I'm Charley Lowry, your host and director of GME Relations at PracticeLink. This show is all about exploring the world of graduate and undergraduate medical education. We'll dive into the real-life experiences, successes, and challenges faced by medical students, residents, and fellows, while also highlighting valuable tools to support you, whether that's financial planning, student aid, or the many free resources provided by PracticeLink. If you're thinking about med school, currently studying, or deep into residency or fellowship, this podcast is here to offer insights and support to make your journey a bit easier than those before you. Welcome back to Surviving and Thriving in Residency. In today's episode, we're joined by Dr. Mubbasher Syed, and we're going to talk a little bit about the future of cardiology. He is an interventional cardiologist, an educator, a program director, and a CVL physician leader. Dr. Syed is an interventional cardiologist and endovascular specialist at First Coast Cardiovascular Institute in Jacksonville, Florida, with expertise in complex coronary intervention and limb preservation. He serves as program director of cardiovascular diseases and associate program director of interventional cardiology at HCA Orange Park Hospital. Board certified in internal medicine, cardiovascular medicine, and interventional cardiology, Dr. Syed is deeply committed to preventive cardiovascular care, innovation in minimally invasive therapies, and advancing patient outcomes through research, education, and quality improvement. Dr. Syed is affiliated with Cardiovascular Logistics, CVL, a physician-led cardiovascular platform focused on scaling cardiovascular care while maintaining physician autonomy and innovation. That's a lot to say. So, Dr. Syed, thank you so much for joining us today. I really appreciate it. How are you doing?
Good. Thank you for a very generous introduction. I'm truly honored to be on this podcast. Thank you for having me.
Of course. So, Dr. Syed, to kick it off for listeners who are hearing your story for the first time, how does someone from the mountains of northern Pakistan become an interventional cardiologist and physician leader in the United States?
Since you're very well traveled and you're very familiar, we just had like a little bit of a pre-recording session, and I have come to appreciate how well traveled and how aware you are of your geography and your cultures. It's not just any mountains, it's the three tallest ranges, right? So Hindu Kush, Karakoram, and Himalayas, they intersect. These are the tallest contiguous ranges. Correct me if I'm wrong, like 10 out of 14 tallest peaks. The 8,000 peaks are in these three ranges, and they intersect in the Gilgit area in the northern Pakistan, the region I'm from. And mountains, have their way. They raise people where there is perseverance. There is a kind of, as a way of life, you learn to live with scarcity, and you know that you have to endure a lot. And there are these roads that are very tough to travel, but they take you to really beautiful places. I think that is a good way to look at my journey becoming an interventionist, and as you said, very generously a physician leader in the United States. It was never like a single, clearly defined ambition. It was just a series of evolving dreams, and that just got refined over time. Opportunities, setbacks, definitely setbacks. I want to stress that along the way. And the quiet prayer of parents and loved ones, because there are people far more capable than me that could be in my position or better, that are not in this position, and opportunities just work out some ways, and you have to always count your blessings and be cognizant how much of your journey is about you and how much of it is just fate, prayers, and the people that have brought you here.
It's so true. Yeah, I think so many people go through their daily lives thinking they can control life, right? And sometimes that's impossible. Life takes you where you're meant to be, I think. So was medicine always your dream?
No, not really. To be very honest, it really has to do more living through my mother's ideal. Like, some kids are really close to their moms. I love my mother very dearly. And mothers have this quiet way, profound way of kind of seeding ideas and ideals in your mind. So ever since I was a kid, my mom is a deeply religious woman, and she always kind of stressed, like, saving a life, saving one life is like saving the whole of humanity. And what better way to earn a living? And she always revered physicians like, everybody else had a profession and then physicians were, and you see yourself through the eyes of your parents, right? So as a child growing up, I was like, if allowed the opportunity, why not? Why not be something that your parents look up to and say, yeah, this is accomplishment in true sense. So I went with that. And then as you travel the journey and you explore, you never know, as they say, the places you will go.
That is so true. So before the cath lab and fellowships and leadership, there was medical school. Tell me about medical school in Pakistan.
So medical school in Pakistan has been an evolving landscape. What it is now, I truly can't speak to as someone who's very familiar with it. I've been out of the country for nearly 2 decades now. But if we go back to when I was applying to medical school, this is like we're talking about late 90s, early 2000s. We didn't have any or many private medical colleges. There were just 2 government subsidized medical schools for the entire province. And this is like we're talking about a province with, back then, I would be remiss if I say somewhere around like 18 to 20 million people living in these provinces, in 2 med schools, like 162 open merit positions and like 6,000 students coming in. And this is like the most brilliant minds. So very, very competitive to get into med school. You get in and then you are all of a sudden amongst the brightest minds in the province at that time. And not just brilliant in their acumen, but people that are very disciplined, people that are very passionate. You don't get to beat the odds that if you don't have an excessive amount of discipline and passion about the field. So just being surrounded by that, and Khyber Medical College, which remains to be a premier institute in the Northwestern Frontier province we're talking about, it is an amazing place. Because not just for its curricular activities, but for its extracurricular and co-curricular activities, from social welfare society and literary society and debating clubs and self-learning forums and all the ways in which you are sitting in a frontier province in a developing country, but you have minds that are looking at like every career path in medicine, everything that is happening in the first world, and you're interacting with all these smart people and trying to figure out what direction you're going in. It challenges you in very significant ways in a very formative phase of your life. And I really owe a lot to those 6 years, which, by the way, medical education is quite different in Pakistan. You have pre-med, and then you get in for roughly 6 years of med school. And then before you can go into any residency training, you have to do 1 year of house job. And house job is like a transitional year in the United States. So you get exposure to 6 months of surgical and 6 months of allied medicine. And then you get to go through what we call FCPS, and which is the equivalent of step 3, and you go through residency. So it's a very comprehensive module and a much longer pathway. So yeah, college was truly a refining moment and a defining moment in terms of where I find myself today.
Do you remember how many roughly were in your class, number size?
Yeah, I remember exactly. So every class was 250 students, give or take. And there used to be like 5 classes because every year used to spill over a few months over the calendar year. So in those 5 years, you had like 1,250 students in the college. And then within those 250 students, as I said, 162 back then, these numbers may have changed a little, but 162 were open merit. Those were just like assigned on merit. And then the rest were reserved seat for like quotas, people that were from what we used to call federally administered tribal areas, which were less privileged in terms of the educational opportunities they get. So if you had a bright mind there, you would reserve quotas for them. These were not applicable to settlers like myself that had gotten education in urban centers like Peshawar or Islamabad or Karachi. So it was beautifully diverse makeup. You get to interact with the best part of every corner of the country. It really sets you up for challenging yourself.
Yeah. And I think that I've heard that you were consistently near the top of your class. What was behind that work ethic? Was that part of pleasing your mom to make sure that you got into medical school, you have to do your best, right?
Since you put me in that spot, that had more to do with my dad than my mom. My father was from very humble beginnings, and he never let us forget that. Inevitably, I keep coming back to my parents because they are a very central thread. Family is a very central thread to my existence. My father, he always reminded me of, as I said, his humble beginnings. And he used to say, education is never something you should take for granted. It is a privilege. The opportunity you have to make most of. He also belonged to that old school generation of dads, not like the dads of today where they have to always cherish you and compliment you. It was very, very hard. It remains very hard to this day to earn a compliment from him or to get a nod of approval from him. So the one thing that always worked was academic excellence. And since childhood, that kind of got ingrained in me. Like if I stay in the top of my class, that's the one thing that makes him smile and nod and feel proud. And that pride itself is something for some kids that can keep them going. But truly, the work ethic was in a deeply rooted desire to make most of every opportunity. It was an intense discomfort with mediocrity, to say it bluntly, not in comparison to others, but within myself. There was this quiet dissatisfaction, like I can do better. Why can't I beat this performance? And that feeling, it pushed me consistently towards preparation and refinement and self-improvement. So yes, it wasn't easy. And if I had to do it again, I don't know how successful I'd be. But looking back, it was well worth it.
Well, I'll share with you words of wisdom from my own father. So his view on education was that's something that no one can take away from you. They can take away everything you own. They can take so much away from you, but education can never be taken away from you. So I've always kept that near and dear to my heart. So let's look back on your younger self. What do you think you misunderstood about medicine then versus now?
Truly, if you ask me, I always thought then that it is an accumulation of facts. If I know the facts, if I can recognize the signs and symptoms, and if I know the treatment algorithms, and if I know which tests to order, and then which medication to order at what dose and what frequency and for how long, and if I knew all the side effects by heart, and I was able to spout out drug interactions, and I knew all the therapeutic procedures and the right referrals and everything, that would make me a great doctor. And that's all that is needed to become a great doctor. And now I am more humbled. I am more humbled, and I've realized that truly the real heart of medicine is understanding the human in front of you and allowing yourself to be there so much that he can share or she can share their vulnerable self with you. They can trust you. They can allow you to make changes that will impact their life. Because nothing is more precious to you or me or any patient for that matter than their life and their health. Creating that bond of trust, earning that from a patient, that is the truth of medicine. And being very cognizant where a patient is coming from. Yes, knowing the guidelines is important. Yes, the algorithms are very crucial. Yes, knowing your facts is critical. I'm not making small of that. But if I go back then, the amount of attention I thought I would have to pay to the human connection, I truly underestimated. I have to put everything in the background when I first enter a patient's room and sit down with them, and I have to connect with them at a human level to understand their financial situations, the stress at their home, what can they manage and what can they not. I would want them to come every 6 months for a follow-up. Can they manage that? Can they afford that? I would want them to be on the most expensive new drug that came out. What is that like for their wallet? What is their transport situation? Can they drive themselves to the clinic? My decisions are so impacted by the realities of a patient's situation in a way that I never anticipated when I was cramming all those facts.
Well, tell me a little bit about the transition to the U.S. medical system. Coming from Pakistan, how was that whole process, not only professionally, but emotionally?
It is something very dear to my heart that this question touches upon, and a bit here and there that in some circles this is brought up quite a bit these days, and it has become kind of a point of conversation in social platforms. And truly these transitions are not easy. I want you to journey with me for a minute and imagine someone who is almost at the summit, and you have done pre-med, you have done these entrance exams, and you have done medical school at a prestigious institution, and you have been consistently performing well, and you're about to complete a house job. Now you gave your FCPS 1 and you're starting residency training. You are barely an year or two from what would be making it if you were born in the United States. And then you're like, no, I'm going to stop here. I'm in my late 20s. I'm going to put all and everything on hold. I'm going to travel across the Atlantic to a foreign country, the culture of which I do not know, the norms of which I do not fully understand, just because I have this desire to work in a technologically advanced, cutting edge, guideline driven, first world practice of medicine. Maybe I can contribute something. Maybe I can be at the cutting edge of innovation. Maybe I can challenge myself to be better and stronger than this. But this is not an easy sacrifice for anyone, where you abandon somewhat, like when you're a step away from making it and you just go to begin again from zero in a completely unfamiliar system. You leave behind not just a training pathway or an identity or a momentum socially, professionally, culturally. You find yourself vulnerable when you land in this country. People don't talk about the financial aspect of it. Most of these countries, like Pakistan, like India, like Sri Lanka, like Bangladesh, like China, like most of these countries where people are coming from, for them to be in the United States without any kind of income, because most of these, like myself included, we come on visitor visas to appear in CS, get some US clinical experience, which has to be non-paid because you're working as an observer and you're on a visitor visa. You can only observe, you cannot participate in any active care. The uncertainty that comes with this and the way you are disrupting set career path just because of ambition. And in a sense, I often think of pioneers like Andreas Grunswig, the father of interventional cardiology, who carried his own vision from Europe here, and he challenged himself in that manner. And I think that is what makes the system and practice of medicine and training in medicine in the United States so appealing for every bright mind from across the globe, is examples like those, because it is those personalities that are willing to disrupt guaranteed success for something bigger, for challenging themselves, for being at the cutting edge of innovation. You want those minds. That is what makes us great and amazing. And when you come here and you mix these minds with US graduates, you're not taking away opportunities from them. You're diversifying those opportunities for them. I really value my collaboration with people that trained here in the United States. I look at the medical schooling here and training here. I work with medical students in my current role, and I feel there is so much that I can take back and contribute to where the other part of the globe is trying to catch up in medical education. And vice versa, there is so much there that I can bring here. These gaps are being bridged by this system in a way we don't talk about enough. This is more constructive and more challenging in ways that people talk about. Ultimately, it's not just endurance, but the decision to begin again when continuing forward would have been so much easier defines a personality that you really, really want to cherish.
So you come to the US and residency. Let's talk about that a little bit. You became chief resident at Cleveland Clinic, Fairview Hospital. Tell me about that. Tell me about residency.
So residency was amazing. Residency for me was not a breaking point. Most people talk about it. For me, it was a validation point, just branching off of the previous conversation we just had. And then starting at Fairview Hospital, Cleveland Clinic's West Hospital, it was a part of their West Side campus network. It felt like a culmination of a long and uncertain journey that had finally come to fruition. By that stage, all the earlier challenges just go into background, and you're like, okay, all the visa-related instability, all the problems of the exams and the clinical experience are behind me now that I have endured, and residency has begun. It's not survival. It feels more like arrival. You feel like every day is an opportunity to prove something. Every day increasingly becomes something you can hold yourself accountable for. Did I put in the amount of effort that does justice to this day that I worked so hard to earn? Could I have done better having traveled from thousands of miles, severed all my connections, and starting here? Have I made most of this opportunity? And that quiet intensity in that period, validation, mixed with accountability, mixed with responsibility. For me, those 3 years in Cleveland, my mentors, my teachers, I cannot cherish a period more in my life. It was without question one of the most energetic and passionate phases of my training career. There was this urgency and curiosity and eagerness and gratitude. I tried to reproduce that day in, day out. I wish I could bottle it back then, go back in time. I still struggle. And in hindsight, I'm very fortunate for that opportunity. I really think that program at that time, Dr. K.V. Gopalakrishna was the program director. Dr. Ahmad Kilani was the associate program director. Dr. Balla was there. Many amazing mentors, many amazing teachers, Dr. Raza in the ICU. I was so fortunate, and it defined me and created me into the physician I am today to an extent that cannot be put into words.
Yeah. And again, I think it goes back to sometimes you think you can control life, but you end up places where you maybe didn't think you would be, or, Cleveland is a cold place to be in the wintertime, but it sounds like it was the perfect spot for you.
Perfect spot. The cold didn't hit me until like 6 years later when I realized maybe it's just a bit too cold.
The typical physician starting her medical career has over $250,000 of student loans. The decisions that young doctors make in their first 3 years of practice will dominate the financial trajectory of the rest of their lives. Our fee-only fiduciary planning program for early career doctors, Foundations, can provide you with the guidance you need to make sound financial decisions. Connect with us at triage.com and use code PRACTICELINK to schedule a free 30-minute consultation with an advisor to talk about your specific financial needs.
So tell me about fellowship. So you were chief fellow as well during your cardiology and interventional fellowships. And what kind of leadership lessons did you learn there?
Yes, indeed. I was very fortunate to be trusted with leadership roles in every chapter of my training career. And I cannot make small of the impact that has on what I do day to day now in my current role in program leadership. It was a beautiful vantage point, starting from residency and then in fellowship and interventional training, where I got to see both sides of the equation. I got to see how decisions are made within the GME leadership, where the program leadership sits down, looks at the problem and sees what's best for the trainees and their education, and then tries to come up with a policy or a workflow. And then you take that as the chief and take it to your trainees, where they have an candid discussion with you about how it's received. I think that intersection where you have one foot in the decision-making circuit and one foot truly candidly receiving, because once you become a program director or associate program director or a core faculty member, trainees don't open up to you like you would want them to. You really want them to tell you honestly what they feel. But many times they will try to tell you what they think you want to hear. I think those chief roles really helped me understand how things can be very different. So I feel like I still carry that perception whenever I'm trying to make a decision. I try to feel like, what is my chief fellow gonna hear in reality when he goes and brings this decision to the trainees? Is it going to be well received? Are they gonna see the educational bargain in this workflow or this change or this policy? So it truly prepared me. It truly told me that for a program to move forward in education and culture, there are certain things that are noise. And the biggest skill that I learned in those roles, whether be it in residency, being a chief resident or a chief fellow, was to how to remove the noise and focus on the real stuff. I really think many people struggle with that. I see that in my administrative role day to day, where a lot of people get bogged down with the noise and focus too much on the noise. There's always noise, but you got to really identify what's really productive and what's truly going to pay off dividends.
So tell me, if you could sit down with your intern self today, what would you tell him?
I would tell him to slow down. And I would truly try to calm him. I would tell him, I know everything feels urgent. I would tell him to understand that competence builds itself one day at a time. I would tell him, don't worry about all the things that you think define you. A missed detail, a difficult day, a moment of doubt, a point where you question a fact that you couldn't recall in time and you had to look up. all this will eventually fade away. What will stay is how you treat people. Try to spend more time seeing patients and watch your attendings and watch your mentors. I cannot make small of this. I truly feel the biggest asset in training is exposure to patients. With no amount of AI or online video platforms on medical education can make up for walking into a patient's room with someone who has been doing it for 10, 15, 20 years and watching them conduct an encounter. That is the real goal. So I knew that as an intern, but it was one of the many things I was focusing on. And I would tell my intern self, it will all come to fruition. Just breathe, relax, slow down.
So tell me, why interventional cardiology specifically?
They used to call it Code Crimson. I don't know if that's still a thing. So I had a deep-seated love for cardiology, and it seemed very black and white to me. It was very definitive, and it was always prestigious, and it had a certain romanticism to it. So I always felt attracted to it, but in a very vague, poetic way. Us people from the mountain, we are very about poetry and analogies and stuff, but not like a specific thing like I definitely want to be a cardiologist. Until Fairview Hospital, they used to call it Code Crimson. It would be like the STEMI alert. Like in most hospitals, they have STEMI alerts. And then just in the middle of the night, usually night float. I remember it very well as in my second month in intern year, I was a night float resident. And during the daytime, you couldn't get any downtime. But in night float, sometimes you would have these 2 a.m., 3 a.m. times where it would be done. It was a busy STEMI center. So if you got a STEMI, a Code Crimson was called, you'd get a page. You didn't have to go. But if you had time and you did end up going, you could actually watch the procedure start to finish and watch it up close and see what the operator is doing, as long as you're not in his way. You would see this sleepy Dr. Nautiyal walking in, or Dr. Maru walking in, or Dr. Basil Musa, and they would just come in and find an LED and open it and balloon it, and ST segments would come down and chest pain would go away and the patient's expressions would change. The amount of stress in the cath lab would automatically change. People would be running around and scrambling, and all of a sudden the balloon would go up and the flow would be restored, and everybody would be like, oh, great, this is amazing. That immediate sense of reward, there was no looking back. I saw that once or twice and I was like, if you want to be involved in patient care and providing relief to patients and feeling that sense of reward it is so immediate and it is so tangible. I never could find a similar calling. I felt like this was it. So I think intern year, I saw a couple of Code Crimsons, and then I would be shadowing the interventionists wherever they would go, trying to pick up equipment, names of wires and catheters, trying to impress upon them my interests, started doing more and more research to kind of further investigate if it is just infatuation or true love. And with time, it kind of became clearer that there was no looking back.
What do residents and cardiology fellows, what do you think they misunderstand most about interventional cardiology?
I'm glad you asked this question as a follow-up, because I felt like what I just said was very incomplete. So this allows me to complete it. What people don't understand about interventional cardiology, what I was too naive to understand, and what I think some of my mentors explained to me, but not in vivid detail. And I try to do a very comprehensive conversation with anyone that comes to me as a resident going into cardiology, or as a cardiology fellow who comes and tells me, hey, I'm very interested in intervention, I want to do this. I know 9 out of 10 times they just saw a STEMI where they felt a sense of immediate reward, and they felt, I know where they're coming from because I can relate to it. So I do like to give them the other side of the coin. And I stress upon them, I said, listen, what you just saw is great, but there is a asymmetry. Yes, it is a heroic save when you open up a vessel. And it is true that most interventionists will save more than they can save. But the emotional weight of the opposite moments is not light. It stays with you for life. Just like the reward is immediate, tangible, very direct, the inability to open a LED in time, the last words you exchange with the patient being the last words the patient ever utters. When God forbid that devastating day arrives, and it will arrive multiple times in the career of every interventionist, where you have to walk that long walk from your cath lab to the waiting room. You do not forget those faces. You do not forget those family members. You do not forget those conversations. They never go away. And there is a huge asymmetry. One of those moments can shadow hundreds of those rewarding moments very easily, depending on who you are. So it's a very misunderstood field in that sense. And I want to use this opportunity to put that out there. I think many people are doing that. The amount of burnout, emotional burnout in interventional cardiology, where the STEMI alert goes off, it's the middle of the night, you know nothing, and you're just driving towards a cath lab, you arrive, and you literally get door-to balloon times is 90 minutes, but that's from the time the patient hits the door of the ER. By the time you have them on the cath lab table, you have somewhere between 15 to 20 minutes. Most patients are very acutely ill and really circling that downward spiral of imminent mortality, or a bad outcome at least. And you have such limited time. And God forbid, on the day you struggle to deliver what you have trained so hard to deliver, it doesn't sit well with you. I always talk about the fine line you have to walk between imposter syndrome and God syndrome. And it's a very narrow path, but there is no other option in this field. You have to stay on that path. You can never credit yourself with your victories, but you can never take your defeats home as personal. And it's so much easier said than done.
I can't even imagine. Well, speaking of imposter syndrome, do you deal with that in the cath lab?
Oh, most definitely. I really think if you have conscience and you're doing enough procedures, one of my attendings used to say, if you don't have complications, you're not doing enough procedures. It's just a number of probability. If you look at the data sets, cross-sectional data sets, you will see that with a certain number of procedures, you're going to have a certain patients that are going to bleed, a certain patients that are going to have contrast-induced nephropathy, a certain amount of proportion of patients that are going to have bad arrhythmias, and a certain number of patients you will lose on the table. What happens when that complication arises? On that day, you are inevitably going to question. It's a human thing. You have to question yourself. Did I do everything right? Did my training fully prepare me for this? Was I the best hands in the lab that day? You think about your mentors and teachers, and I have worked with some of the most amazing folks. I think about Ihab al-Tahawi and Mujib Sheikh and Haider Yassin and Ashish Prashad. These are people that trained me, or people that I still work with that are amazing, like Yazan Khatib, Yusuf al-Saghir. In that moment, you are left questioning yourself, could it have been that there had been another operator in this lab? Could the outcome have been different? That is a very true question, and you don't want to abandon that, because that is what refines you. And I know very few interventionists that do not share their cases with 2 or 3 people that they really trust, whose judgment they really trust. I definitely have my Michael Megali and my Yazan Khatib and my Yusuf al-Saghir. I send my Ziyad al-Nabki. I send my cases to them. I say, hey, this is the situation. This is what I did. Should I have done something differently? So you have to be humble. I think a degree of humble and conscious effort is needed to keep questioning yourself, keep holding yourself accountable. And with that, a little bit of imposter syndrome starts creeping in, and you have to keep that at bay. Because in the lab, on the day when a patient is in an acute situation, you do not want to be looking for your confidence. And imposter syndrome is the enemy of confidence. On that day, you want to be the most confident in your skill and your ability and your acumen. So I tell my trainees all the time, and myself, yes, always keep checking. Yes, always hold yourself accountable. Yes, have that extra set of eyes to keep reviewing your cases and your complications, to keep you humble and straight and on the right path, and making sure you are doing everything as is best, as is the standard of care. But don't let imposter syndrome creep in, because the day you feel like an imposter, you are a less capable physician. The same technical skill set, the same training becomes less effective the minute you start feeling like an imposter. So it's a constant struggle. It is an everyday struggle. It creeps in. You have to check it at the door of the cath lab. When you walk into the procedure room, you have to collect yourself. It is a conscious collection of your thought, and you have to just refocus and realign yourself.
I think that is absolutely incredible. What about a support network? You have people, like you say, you have people that you reach out to when you question yourself, did I do this right? But what about a support network as well? People that you surround yourself with that you can talk to. I mean, you don't want to internalize when you maybe lose a patient that day, or you have a rough day, or maybe lose several patients in a day. That's a high possibility, right? So how do you surround yourself with the right people that you can let that go and kind of reset yourself?
Exactly. And I tell, especially my interventional fellows, I stress this very much. And it doesn't have to be uniform. It doesn't have to be organized. But you need to have people to whom you can show your vulnerability, your self-doubt, and tell them to bring you back and realign them. It could be someone in the cath lab. And I have staff members in the cath lab that have worked with me over the last 6 years that have become from co-workers to friends to family, who do this day in, day out, who will keep me humble and say, oh yeah, maybe we should have done this first or this second or this. There are people that I haven't worked with in the last 6 years since training, like my interventional co-fellow, Michael Megali, is a very good friend. My co-worker, Ziad Al-Nabki, my wife, who is fortunately a physician. The emotional aspect of this, because she is a physician, I go home sometimes and I tell her, she just looks at me and she's like, what happened? And I was like, without giving her patient details, I was like, it was a rough day. I had 2 patients where this happened and 1 patient where this happened. Because you can't take that to bed. Maybe one day you can, maybe 2 days you can. But if you take that to bed every day, the burnout is real. Despite these support networks, the burnout is real. So you really have to create your own system, and there is no standardized way. Maybe it's something that's needed at a system-based level, but just having those mentors. My program director from my cardiology days, Dr. Al-Tahawi, Dr. Sheikh, I still sometimes reach out to them and say, hey, you have been doing this for like 10, 15, 20 years more than me. So this is what I'm dealing with. Am I doing this right? And this is how I'm feeling. And truly, experience cannot be taught. It has to be bought. So they can just give you one line that just realigns everything and makes it make sense. But yes, it is critical. You cannot be in a high acuity field like this with so much unpredictability and not have a good support network.
On this podcast, I think this is some of the greatest words of wisdom that I have heard. Just very sincere and from the heart, and I really do appreciate it. So you've spoken passionately about prevention. Why do you think preventive cardiology is still underutilized?
One of the few subjects that if you say those words, you can just leave me with a mic for an hour and I can keep talking. One of them is preventive cardiology, and it's like an oxymoron, right? I'm an interventional cardiologist who just goes in to put out a fire. Prevention is so far from me. That is the specific reason I'm so passionate about it, because I see the downstream effects. I see the downstream effects of it every day. Every day, like this morning in didactic conference, just for an example, we talked about a patient whose A1C was 6.7 2 years ago, and nobody counseled the patient or explained to her, and it went to 11. She didn't even know she was diabetic, and it turned to such a coronary disaster. And that's just one anecdote, but truly, if you look at the cross-sectional data like REACH registry or anything, despite knowing that guideline-directed medical therapy is crucial in heart failure, that statins are part and parcel of a diagnosis of coronary artery disease and peripheral arterial disease, that you cannot spare antiplatelets when you have had a coronary or a peripheral disease event like limb ischemia or acute coronary syndrome. The adherence in United States, we're not talking about some third world country, we're talking about United States with all the healthcare dollars going into the system, all the amazing GME activities, all the training, all the protocols, all the seminars and educational conferences. Despite everything, we have not scratched 60% in terms of adherence, which means nearly half of the patients are not on therapies that we know lower heart attacks, that we know prevents amputations, that we know prevents heart failure exacerbations, that we know lower mortality, the biggest goal of medicine, lowering mortality. We have mortality lowering therapies that are not being prescribed despite patients going to physicians and seeing them. Now, there are many system-based changes that are needed. Maybe there is some more education that is needed. But to an end, what is needed is activism. Activism about these causes. These are the causes to take up. These are the things to talk about. And I think it is unnatural, as I said, for an interventional cardiologist to talk about it, but I also feel it is very relevant because I have that moment of vulnerability. I truly, unfortunately, participate more in secondary prevention than primary prevention. I do meet patients more often after their heart attack, after they have, God forbid, had an amputation or almost had an amputation due to chronic limb-threatening ischemia. But when I do meet them, I tell them, let's make this a second chance that we are going to capture and make most of. Let's make sure we are not a metric where we are the 40-50% that are not on antiplatelets, on statins, not getting surveillance ultrasounds, not screening. Everything that the United States Preventative Task Force puts out, or that we have a clear class 1 indication to follow, should be part and parcel of a physician visit. And if you're not vocal about this, if you're not passionate about this, then you're missing the point. You're losing the opportunity to move the buck upstream, to stop an event before it's happening. I really think it's a very intuitive goal, despite the paradox given my choice of work.
So how are imaging, AI, and new technologies, how is that changing cardiovascular medicine?
Dramatically, and not enough yet, but just around the corner. And I have these conversations with my fellows quite too often now, especially because in the last maybe 8 to 9 months, AI, that was something we used to talk about as fiction, has become really tangible with ChatGPT and Claude and Grok, and everything is out there, and everybody is like seeing how it is writing their emails and their essays and their discussion sections and assembling PowerPoints for them. So it's not something that is far flung. It is there, and people can touch it and feel it and participate in it. So now the questions are real. We were talking about this for years, but now everybody feels that it has arrived. And now when you have a conversation, the audience is way more attentive. But I really feel it has been a long time coming, and we're turning that corner. And of course, everybody has their opinions, and there are thought leaders in the industry that talk about this a lot. My personal money is on AI, it's on convergence, if that makes sense. I really think imaging and the technological advancement in imaging, where cardiac MR is going, where photon counting CTs are going, like the photon counting CTs and their resolution is amazing. Cardiac MR is making leaps and bounds. PET CT has made some turns that are unimaginable. In invasive imaging, near infrared spectroscopy, where you can actually analyze the chemical composition of plaques and how it is getting integrated with probes that can do intravascular ultrasound imaging and optical coherence tomography all together in one set. These are technological leaps on one end. Then you have population data, which is all these wearable devices and all these things that people can put their fingers on and get EKGs and all that. And that is all being collected. Now, this data and this advancement could not have been married without AI. When you put AI on top of this, it converges these two very amazing data sets and capabilities into one fluid system that can screen and diagnose. So for cardiovascular medicine in general and interventional cardiology specifically are truly allied medicine specialties. Everyone, internal medicine, gastroenterology, hematology, oncology, rheumatology, everyone is about to experience an amazing era. And people have dread. I am thrilled and super excited because what we are about to see is diagnosis and screening of high-risk populations right before those sentinel events. Right before an MI is about to happen, right before a limb is about to shut down, right before the patient goes downhill into dialysis, we are going to be able to pick these patients up. And what we do with that data set is going to be something that's going to need so many smart and brilliant and well-trained doctors. Because I'm going to just make a turn here. A lot of people are very nervous because everybody keeps talking about AI is going to take my job away and AI is coming and what are we going to do? Elon Musk said we're not going to need physicians. I was like, no, you're going to need so many more physicians. You're just going to need very smart physicians that can adapt very, very fast, because what you learn and train in med school is just going to be ABC. It's going to be alphabets. You're going to be expected to make words and sentences out of it like you don't have an imagination right now. So it's a very exciting and truly unpredictable. This is my theory and everybody has a theory, and that's the beauty of it. It's fascinatingly exciting.
It is. It truly is. And one thing with AI is it doesn't have that ability to come into the room and put their hand on your knee and calm you down. It doesn't have that compassion element. There are so many things that are missing that are crucial to survival with the human species, I think.
Very true. And truly, this is something, again, branching off of that question, so perfect. Your transitions are so perfect. It is so crucial to give this surety and this security to every trainee in medicine right now, because there's a lot of chatter. And back to noise, I feel it's all noise. I really feel, I keep telling my trainees, hey, buckle down, stop focusing on the noise, learn to diagnose, learn to treat, learn to walk into a patient. Elon Musk himself had this beautiful podcast. Someone asked him about AI taking over all these jobs, and he said, those people that move digits are going to be unsafe under the future where AI is ruling. But those people that move atoms are going to be safe. And I always quote that to my fellows. I was like, listen, be someone that moves atoms, and no AI robot is coming in to auscultate your patient. Nobody is going to come and take care of an acutely sick patient that is crashing. You guys move atoms. You are safe. Don't worry. Yes, AI, it is like the Industrial Revolution. It is going to downsize big time, and a lot of careers are unsafe, and it is the reality. It is the harsh reality. And even medicine, I don't want to make it sound all beautiful and happy ever after. It is going to have to reinvent itself big time. It is going to have to challenge itself and adapt and incorporate and integrate in ways that it can't be even verbalized right now. That said, I don't think physicians are going to be out of jobs. I think physicians will have to learn newer workflows and newer ways to help patients. And it's going to be more exciting if the goal is to help patients, because truly, I do believe we will be able to help more patients.
At PracticeLink, we believe your physician job search should be simple, supportive, and stress-free. That's why creating an account has always been and will always be completely free for physicians. Create your free account today at PracticeLink.com to start receiving your latest and most exclusive job opportunities directly to your inbox.
So let's transition over to CVL. So it describes itself as a physician-led cardiovascular platform focused on preserving physician autonomy while scaling cardiovascular care nationally. So tell us a little bit about cardiovascular logistics, if you would.
Cardiovascular logistics, as you very beautifully, aptly described, is a physician-led platform, and physician-led cardiovascular platforms, because I'm a cardiovascular medicine physician, I have to refocus on that aspect. They are becoming increasingly important. And it is because the care of a cardiovascular patient has become too complex. It has become too longitudinal, too technologically driven. And for it to be fully optimized, and for all these small systems that are evolving so rapidly, you need to have clinical leadership at the center of it. That, I think, is the central theme of why physician-led platforms are important. When physicians are actively guiding these systems, the focus stays anchored where it matters the most. And I feel very strongly about this: patient outcomes, appropriateness of care, a continuous refinement of evidence-based practice. It will help align evolving along with things like AI, like we were just talking about, with upcoming newer imaging modalities and structural interventions and complex pharmacotherapy in real world. When you have to do these administrative leaps You have to make these administrative leaps truly from a financial, logistical, or administrative standpoint without clinical input. Those are not going to be patient-centered decisions. We see this in big hospital systems where C-suites do not have enough physician representation. And truly it branches out into site of service neutrality arguments. But without diverging there at this point, just to briefly and succinctly answer your question, cardiovascular logistics is one of the many cardiovascular platforms where physicians are coming together to create a scale where they are impactful. Because if you are 5 cardiologists in Jacksonville, or 10 or 15, and 20 cardiologists somewhere in Louisiana, and 10 guys practicing in Tampa, and 20 guys practicing in Albany, in those small microcosms, you are only so relevant. Your conversations are so limited in their impact. But when you integrate these 4 or 5 practices and you create a scale where now 200 cardiologists are making a point that this is where imaging is going, and this is better for patients, and this is how guideline-directed medical therapy should be enforced. These are better settings for this procedure. This is what is better for the patient in terms of outcomes. You're not speaking from a scale of 5, 10, 15 cardiologists. Now you represent a platform where you have a bigger audience. And I really think in terms of bringing clinicians back into the conversations regarding decision-making in healthcare, these are very essential steps, very crucial, very critical building blocks that will lead us into a future where we will make decisions that are smarter for our patients and for our healthcare dollars. We really are struggling despite having spent more healthcare dollars than any nation in the history of humankind on healthcare. And we are still not in the top 20 in most indices of healthcare, whether it's maternal mortality or infant mortality or cardiovascular care. Why? We need to bring physicians back to the conversation. We need to realign our focus. And I think these platforms are really setting the stage for a bigger conversation at a national level.
So, kind of along those lines, what are the biggest operational challenges that cardiovascular practices are facing today?
Exactly that. Scaling cardiovascular care has become so hard because when you had a small practice and when you went into a cardiology practice, a private practice, up until like 10, 20 years ago, you were creating that deeply personal physician-patient relationship in that location. You were connecting to your community. And the way to keep that intact was to stay as a 10, 12 cardiology practice. And then all of a sudden you realize that you will never get a seat at the table that matters, the table that will truly make the decisions that will impact downstream care for your patients. So you need to scale yourself. And when you start scaling yourself, you have to constantly balance yourself between losing that culture. So you have to constantly worry about preserving that culture of a small practice where you have a one-on-one relationship with your patient along with operational efficiency, because then all of a sudden you're bringing in administrative folks that are trying to make you more efficient, more fluid, bigger, and scaling you, as they say. So it is a constant struggle. As systems consolidate, many practices will find themselves in these challenging circumstances. You don't want to become very corporate like large hospital systems. You want to prioritize standardization and regulation across platforms, but at the same time, you have that risk that you're going to begin to sound transactional like big hospital systems. You want to preserve that feeling of that corner doctor's office where the patient knows exactly the physician he'll see or she'll see and they can connect to them. So it's a difficult navigation for cardiology practices as these operational challenges become more and more. I really feel it was so much easier to just graduate and start a practice with 2-3 other colleagues maybe 20 years ago. Today, it is daunting.
So what do you think the next 10 to 15 years will bring for cardiovascular medicine?
I think things will continue to move out of hospitals. I really think outpatient migration is here and here to stay. And you see that in the 2025 CMS approved procedure list for ASCs and office-based labs. There's going to be a lot more hybrid labs, office-based labs. There are going to be a lot more ambulatory surgical centers. It's not going to remain theoretical. I think we will have to evolve in a way where we can function as a smarter system overall. And it will have to happen hand in hand with the hospital systems. And I think the hospitals understand that. In conversations with hospital system, we are not seeing resistance. We are seeing collaboration. I think they realize too that the current system is not sustainable. And I think everybody has a stake in making it self-sustaining. And that requires certain changes in the next 10 to 15 years. I think we have begun seeing the implementation of these changes in the next year or two. And between now and 2035, I feel in these next 9 years, my personal prediction is there's going to be a lot more integration of outpatient spaces with ambulatory procedures and hospitals where the flow between the two is going to become very dynamic instead of being separate entities like it is right now.
Well, how about advice for young cardiologists? How can they prepare for the rapidly evolving healthcare landscape?
Move atoms, not digits. Move atoms, not digits. No, truly, in a rapidly digitizing healthcare landscape, it is so easy to get pulled towards metrics, dashboards, coding cultures, abstract performance indicators, KPIs, right? Key performance indicators. Those matter. They do matter, but they're not the patient. And that's the point. For every trainee, that is the most critical point. Cardiovascular medicine ultimately changes when you influence real physiology. Your blood pressure, your flow, the integrity of the plaque in your coronary vessels and the rhythm of your heart and the outcomes in the body right in front of your eyes. That is what preparation is for. That is what training is for. So young cardiologists who are stepping into this, yes, worry about what's up ahead, but also make sure you are grounded well. If you are clinically intact and your heart is in the right place. These things are very simple. You shouldn't have to choose between technology and bedside medicine is what I'm trying to say. One integrates with the other. Using advanced tools to better patient outcomes with a clear understanding of clinical medicine is what is expected of the future cardiologist. And the first step in that is being good clinically, being good at diagnosis, being good at treatment.
So how about the role that they should play in shaping healthcare systems instead of just working inside them?
They should actively help define those systems become better. We are bad activists. Physicians, we like to come in and see patient and patient and patient and patient and patient and patient until the last patient checks out, and then we go home and we are too tired to do anything else. And that is the reality of medicine. But essentially, to shape a healthcare system, you have to sometimes find time to reflect and ponder and take a step back and look at your routine and see what are you doing day in, day out, and are you truly making a difference? And if you are, is this the maximum difference you can make? What is missing? What can be done to make you a more effective tool in the shed? Because that's all you are. Never get God complex. You're a very sharp tool, but you are a tool in a very complex, big shed. But are you being used to your maximum? Are you using the tools at your disposal at the maximum? What are the system-based changes that you can make to improve it? Small things are never too small. I have so many examples of the smallest things that I pick up during clinical routine, and I talk to one administrator who has no clinical background, but he or she is so willing and so eager to make something that will impact patients positively. You just go and whisper it to them and say, hey, I noticed that these patients that are going home, they often are confused about the doctors that saw them. So if they had like a handout with physician names and designations, like which one was a cardiologist and which one was a gastroenterologist and where are their offices and everything. It would really help them remember those encounters, because it becomes a blur when you are 3 days in the hospital. And next day you walk in and those handouts are there. You don't have to do much. You just need to find the right person and whisper something that is in your mind. But for that, you need to take a step back and reflect and ponder and be invested in your community, in your hospital. You have to own it. Just like you own your own house, you have to own your hospital and your practice and your patients, and constantly question, can I do better? Can I add one more thing where someone will feel more comfortable? And if that is the mindset, the healthcare system will continue to shape into something better and better and better until we are all patients and we need that care, and we will be thankful for it.
That's so great. So as we kind of wind down here, let's reflect a little bit. So advice. So we have a lot of listeners who are pre-med. We have a lot of listeners who are medical students, a lot of residents, a lot of fellows. Looking back on your journey from day one to now, what advice would you give those listeners? What words of wisdom would you share with them?
I would truly tell them that what they're feeling often is not a sign of inadequacy. It is often a sign of sustained effort without recovery, reflection, or reward. Constantly questioning yourself is common with the personality that gravitates to a very competitive field like medicine. It also is the reason we have such a high rate of burnout. I want to stress that medicine can compress identity. It can make you feel like your current level of fatigue is your permanent level of your ability and functioning, and you get this burnout when you are continuously in a competitive state, because from pre-entrance, from your MCATs onto your med school, onto competing with your med students, and then getting into residency, and then getting into your young career, throughout that whole journey, you don't get breaks. You are in a constant competitive situation. So it is very, very important to realign yourself and keep reminding yourself at every point in this journey that this stage is not the finished product. Don't have that kind of expectation from yourself, because then you have that kind of disappointment from yourself. And if you're disappointed in yourself, it becomes near impossible to continue evolving. So always be open to feedback, see more patients, gather more experiences, more encounters, shadow more physicians, get into as many rooms and as many operating rooms and as many cath labs as you can. No experience is wasted. You never know what will come in handy. I learned things on my plastic surgery and dermatology rotation that I still sometimes reflect on and use day to day in my patient encounters. You never know what is going to come in handy. So if you are in that place, the goal is not to feel perfect. It is to stay in the game. It is to take care of yourself and to make sure you have the will and the trust to cross the finish line, because competence and confidence are accumulated. They're not instant. You can't see someone at the age of 45 and 50 and say, I don't have that. Well, that guy didn't have it too.
Right. So how do you decompress from such a high intensity field?
I do need my decompression modules, I will tell you. It does get stressful at times. I am very fortunate. I have 3 well-designed, naturally calibrated decompression modules. One is 9-year-old, her name is Sakina. One is 3-year-old, her name is Zainab. And one is 2 years old, and her name is Fatima. These are my 3 daughters. And they have a way of completely resetting perspective. I swear, I call them my walking, talking SSRIs. I just walk into home, and the intensity or weight from all day of clinical work and difficult decision making, it is just taken away by the kind of energy and innocence they bring in. And truly beyond that, I'm very fortunate. I have a large and loving extended family, my siblings, my nieces, my nephews. They provide me a sense of grounding that is hard to replicate with any other aspect. Yes, I do cook and I do work in the backyard. Those are my favorite things to do, because there is something very stabilizing about activities like that. They pull you out of the tempo of hospitals and just deadlines and put you back into something slower, more tangible and very human. But I'm truly a very grateful man. I think family is the central theme of my existence, and it truly helps me with emotional recalibration, in a way where returning to work with a clearer mind and a more stable center becomes possible.
Yeah, a lot of times on the program, we talk about keeping mind, body, and spirit in check. And that's so crucial and so important, especially for a medical student or resident, but even for a practicing cardiologist like yourself, mind, body, spirit. If they're not in balance and in check, you're going to have problems, right?
Entirely true. I could not disagree with any word. It is central and pivotal to any career. And truly every career is going through the same rigor. It is becoming more and more challenging. Technology has helped, but also made it difficult in ways. You have the amount of paperwork and the amount of checklists, the amount of steps, the amount of things you have to go through in medicine or any career has changed dramatically over the course of the last 2 decades. So you have to keep the mind, body, and spirit in mind all the time and be very cognizant about repairing as you go.
Well, I cannot thank you enough for being a guest today. I'd love to have you back for 10 more episodes. I think we have so much more to cover. Great words of wisdom today, for sure. But before we wrap up, I would like to leave our audience with a few resources, because surviving and thriving isn't just about mindset. It's about having the right support. And if you're a resident, fellow, or early career physician, keep us in mind. We do a lot. Our scholarship is closing actually today. As we're recording, it will close at the end of the day today, but we will open that again for the fall. And that is the First Practice Fund. So keep your eye open for that opening up for the fall. We do offer free CV reviews. And we also offer lunch and learn sessions, practical real world guidance on contracts, compensation, and navigating your career. And don't forget, the Practice Link job board is completely free for physicians with no catch. It's one of the best ways to explore opportunities when you're ready. Everything you need will be linked in the show notes. And if this episode resonated with you, share it with a co-resident, a friend, or someone who really needs to hear it. And as always, remember, residency isn't just something you survive, it's something you can come to learn to grow through. Thanks for listening to Surviving and Thriving in Residency, and we will see you next time.